Anticoagulants, often referred to as blood thinners, are a class of medications designed to prevent or treat blood clots. They play a crucial role in preventing life-threatening conditions such as deep vein thrombosis, DVT, pulmonary embolism, PE, stroke, and heart attack. Mechanism of action. Anticoagulants work by interfering with the body's natural clotting mechanism, known as the coagulation cascade. This cascade involves a series of proteins that interact to form a blood clot. Anticoagulants target specific components of this cascade, preventing the formation of clots or breaking down existing ones. Types of anticoagulants. There are several types of anticoagulants, each with its unique mechanism of action and clinical applications. Vitamin K antagonists, VKAs. Mechanism, VKAs, such as warfarin, inhibit vitamin K reductase, a key enzyme involved in the activation of clotting factors 2, 7, 9, and X. This inhibition leads to a decrease in the production of these factors, resulting in impaired blood clotting. Clinical uses. VKAs are primarily used for long-term prevention and treatment of venous thromboembolism, VTE, atrial fibrillation, and other thromboembolic conditions. Monitoring. The effectiveness of VKAs is monitored through regular blood tests called International Normalized Ratio, INR measurements. The INR measures the blood's clotting time and helps determine the appropriate dosage of warfarin. Heparins. Mechanism. Heparins enhance the activity of antithrombin III, a naturally occurring anticoagulant protein. Antithrombin III inactivates several clotting factors, including thrombin and factor XA. Types. Unfractionated heparin, UFH. UFH is a heterogeneous mixture of heparin molecules with varying molecular weights. It is administered intravenously and has a rapid onset of action. Low molecular weight heparin, LMWH. LMWH is a purified form of heparin with a lower molecular weight. It has a more predictable anticoagulant effect and is often administered subcutaneously. Clinical uses. Heparins are used for the acute treatment of VTE, prevention of VTE during surgery, and treatment of unstable angina and myocardial infarction. Monitoring. The anticoagulant effect of UFH is monitored through activated partial thromboplastin time, APTT measurements. LMWH typically does not require routine monitoring. Direct oral anticoagulants, DOACs. Mechanism. DOACs directly inhibit specific clotting factors, bypassing the need for vitamin K or antithrombin III. Types. Direct thrombin inhibitors, DTIs. DTIs, such as dabigatran, directly inhibit thrombin, the final enzyme in the coagulation cascade. Direct factor XA inhibitors, FXAIs. FXAIs, such as rivaroxaban, apixaban, and edoxaban, directly inhibit factor XA, a key enzyme in the coagulation cascade. Clinical uses. DOACs are widely used for the prevention and treatment of VTE and atrial fibrillation. Monitoring. Most DOACs do not require routine monitoring, although specific antidotes are available for reversal in case of bleeding complications. Pharmacokinetics. The pharmacokinetics of anticoagulants, including absorption, distribution, metabolism, and elimination, vary depending on the specific drug. Some anticoagulants, such as VKAs, have a narrow therapeutic window, meaning that small changes in dosage can significantly affect their anticoagulant effect. Others, such as DOACs, have a wider therapeutic window and are less sensitive to dosage adjustments. Clinical considerations. The choice of anticoagulant depends on various factors, including the patient's medical history, the specific condition being treated, and potential drug interactions. It is essential to carefully monitor patients receiving anticoagulant therapy to assess their response and adjust the dosage as needed. Adverse effects. A major concern with anticoagulant therapy is the risk of bleeding. Thrombolytics, also known as fibrinolytic agents, are medications designed to dissolve blood clots. They play a crucial role in the treatment of acute thromboembolic conditions, such as acute myocardial infarction, heart attack, and acute ischemic stroke. Mechanism of action. Thrombolytics work by activating the body's natural fibrinolytic system, which involves the breakdown of fibrin, the protein that forms the meshwork of a blood clot. They target specific components of this system, leading to the dissolution of the clot and restoration of blood flow to the affected tissue. Types of thrombolytics. The most commonly used thrombolytics belong to two main categories. Tissue plasminogen activator, TPA. Mechanism. TPA is a recombinant form of human tissue plasminogen activator, a naturally occurring enzyme that converts plasminogen to plasmin. Plasmin is a powerful enzyme that breaks down fibrin, leading to clot dissolution. Clinical uses. TPA is the primary thrombolytic agent used in the treatment of acute myocardial infarction and acute ischemic stroke. It is administered intravenously and has a rapid onset of action. Streptokinase. Mechanism. Streptokinase is a bacterial enzyme that activates plasminogen to plasmin, similar to TPA. However, it is less specific than TPA and can cause systemic fibrinolysis, leading to a higher risk of bleeding. Clinical uses. Streptokinase is less commonly used than TPA due to its higher risk of bleeding. It is primarily used in settings where TPA is not available or contraindicated. Pharmacokinetics. The pharmacokinetics of thrombolytics, including absorption, distribution, metabolism, and elimination, vary depending on the specific drug. They are typically administered intravenously, and their distribution is primarily within the blood vessels. The metabolism and elimination of thrombolytics occur in the liver and kidneys. Clinical considerations. The use of thrombolytics is associated with a significant risk of bleeding. Therefore, careful patient selection and risk assessment are essential before initiating thrombolytic therapy. Patients with active bleeding, recent major surgery, or uncontrolled hypertension are generally excluded from thrombolytic therapy. Adverse effects. The most common adverse effect of thrombolytic therapy is bleeding, which can range from minor bleeding to life-threatening hemorrhage. Other potential adverse effects include allergic reactions, hypotension, and arrhythmias. Monitoring patients receiving thrombolytic therapy require close monitoring for signs of bleeding, including changes in vital signs, hematuria, and gastrointestinal bleeding. Laboratory tests, such as complete blood count and coagulation studies, may be used to assess bleeding risk and monitor the effects of thrombolytic therapy. Conclusion. Thrombolytics are powerful medications that can significantly improve outcomes in patients with acute thromboembolic conditions. However, their use is associated with a significant risk of bleeding. Careful patient selection, risk assessment, and monitoring are essential to optimize the benefits and minimize the risks of thrombolytic therapy. Antiplatelet drugs. A primer. Antiplatelet drugs are medications designed to prevent blood clots. They work by inhibiting platelet activation and aggregation, thus reducing the risk of thrombotic events such as heart attack and stroke. Mechanism of action. Platelets play a crucial role in blood clotting. When a blood vessel is injured, platelets adhere to the injured site and activate, releasing substances that recruit more platelets and initiate the formation of a blood clot. Antiplatelet drugs interfere with various steps in this process, preventing platelet activation and aggregation. Types of antiplatelet drugs. Cyclooxygenase, COX. Inhibitors. Aspirin. Aspirin irreversibly inhibits COX-1, an enzyme that produces thromboxane A2, a potent platelet activator. This inhibition reduces platelet aggregation and prolongs bleeding time. Aspirin is widely used for the primary and secondary prevention of cardiovascular events. Adenosine diphosphate, ADP. Receptor inhibitors, P2Y12 receptor inhibitors. These drugs, such as clopidogrel, ticagrelor, and prasugrel, selectively block the P2Y12 receptor on platelets, preventing ADP-induced platelet activation and aggregation. They are commonly used in combination with aspirin to prevent cardiovascular events, especially after percutaneous coronary intervention, PCI. Glycoprotein 2B or 3A receptor inhibitors. Abiciximab, tirofiban, eptifibatide. These drugs block the glycoprotein PAB3A receptor on platelets, inhibiting the final common pathway of platelet aggregation. They are primarily used in high-risk patients undergoing PCI to prevent stent thrombosis. Clinical uses of antiplatelet drugs. Primary prevention of cardiovascular disease. Aspirin is often used to reduce the risk of heart attack and stroke in individuals with risk factors such as hypertension, hyperlipidemia, and smoking. Secondary prevention of cardiovascular disease. After a heart attack or stroke, a combination of aspirin and a P2Y12 receptor inhibitor is typically prescribed to reduce the risk of recurrent events. Acute coronary syndromes. Antiplatelet drugs, including aspirin and P2Y12 receptor inhibitors, are essential components of the treatment of acute coronary syndromes, such as unstable angina and myocardial infarction. Peripheral arterial disease. Antiplatelet therapy, often including aspirin, can help improve blood flow to the legs and reduce the risk of cardiovascular events in patients with peripheral arterial disease. Adverse effects. The most common adverse effect of antiplatelet drugs is bleeding. This risk is increased in patients with underlying bleeding disorders, those taking other medications that affect blood clotting, and the elderly. Other potential adverse effects include gastrointestinal disturbances, such as dyspepsia and ulcers. Regular monitoring of patients on antiplatelet therapy is crucial to assess for bleeding complications. In some cases, blood tests may be used to monitor platelet function, but this is not routinely required. In conclusion, antiplatelet drugs are essential medications for the prevention and treatment of cardiovascular disease. Understanding their mechanisms of action, clinical uses, and potential adverse effects is crucial for their safe and effective use. Blood disorder medications. A comprehensive overview. Blood disorders encompass a wide range of conditions affecting the blood and blood-forming organs. Medications used to treat these disorders target various aspects of blood cell production, function, and destruction. Anemia medications. Anemia is a condition characterized by a deficiency of red blood cells, or hemoglobin. Medications used to treat anemia aim to increase red blood cell production or improve oxygen-carrying capacity. Iron supplements. Iron is essential for hemoglobin synthesis. Iron deficiency anemia is treated with oral or intravenous iron supplements. Vitamin B12 and folic acid. These vitamins are crucial for DNA synthesis and red blood cell maturation. Deficiency of either can lead to megaloblastic anemia. Erythropoietin-stimulating agents, ESAs. ESAs, such as erythropoietin and darbepoetin alpha, stimulate red blood cell production in the bone marrow. They are used to treat anemia associated with chronic kidney disease, cancer chemotherapy, and other conditions. Thrombocytopenia medications. Thrombocytopenia is a condition characterized by a low platelet count. which can increase the risk of bleeding. Thrombopoietin receptor agonists, TPAs. TPAs, such as romoplastim and L-trombopag, stimulate platelet production by activating the thrombopoietin receptor on megakaryocytes. They are used to treat chronic immune thrombocytopenic purpura, ITP, hemophilia medications. Hemophilia is a bleeding disorder caused by a deficiency of specific clotting factors. Clotting factor. Concentrates. These concentrates contain specific clotting factors such as factor 1 or factor 9, which are missing in individuals with hemophilia A or B respectively. They are administered intravenously to control bleeding episodes. Desmopressin. Desmopressin is a synthetic analog of vasopressin that stimulates the release of von Willebrand factor and factor VIII from endothelial cells. It is used to treat mild hemophilia A and von Willebrand disease. Anticoagulant medications. Anticoagulant medications prevent blood clots from forming. Vitamin K antagonists, VKAs. Warfarin is a commonly used VKA that inhibits vitamin K-dependent clotting factors. It is used to prevent blood clots in conditions such as atrial fibrillation and deep vein thrombosis. Direct oral anticoagulants, DOACs. DOACs such as rivaroxaban, apixaban, edoxaban, and dabigatran directly inhibit specific clotting factors. They are used as alternatives to warfarin for the prevention and treatment of blood clots. Heparin. Heparin enhances the activity of antithrombin 3, a natural anticoagulant. It is used for the acute treatment of blood clots and to prevent blood clots during surgery. Antiplatelet medications. Antiplatelet medications prevent platelets from sticking together and forming clots. Aspirin. Aspirin inhibits platelet aggregation by irreversibly inhibiting cyclooxygenase 1, CUX1. It is widely used to prevent heart attacks and strokes. P2Y12 receptor inhibitors, clopidogrel, ticagrelor, and prasugrel inhibit the P2Y12 receptor on platelets, preventing platelet activation, and they are used to prevent blood clots after a heart attack or stent placement. Immunomodulatory medications. Immunomodulatory medications target the immune system to treat blood disorders caused by autoimmune reactions. Corticosteroids. Corticosteroids, such as prednisone, suppress the immune system and reduce inflammation. They are used to treat autoimmune thrombocytopenic purpura, ITP, and other autoimmune blood disorders. Immunosuppressants. Immunosuppressants, such as cyclosporine and tacrolimus, suppress the immune system to prevent it from attacking blood cells. They are used to treat severe cases of ITP and other autoimmune blood disorders. Note: the choice of medication and dosage depends on the specific blood disorder, its severity, and the individual patient's characteristics.